Congenital heart disease or congenital malformation of the heart, commonly referred to as hole in heart, is quite a common malformation with an incidence of 8 out of 1,000 live births. There are two main groups of congenital heart disease, namely acyanotic and cyanotic. The acyanotic types include ventricular septal defect, atrial septal defect, patent ductus arteriosus, as well as aortic stenosis, pulmonary stenosis, and coarctation of the aorta. The cyanotic types are associated with a mixing of deoxygenated blood with oxygenated blood, and these include tetralogy of Fallot and transposition of the great arteries. So early recognition of the specific type and appropriate medical or surgical intervention is important in improving the quality of life and reducing morbidity from complications. So the causes are genetic, as there's higher risk with increasing maternal age, as it could be idiopathic and maternal infections due to viruses in early pregnancy, notably rubella, and also maternal diabetes. Alcohol, smoking, and use of drugs during early pregnancy could cause this. Exposure to X-rays and other radiation during early pregnancy, prematurity, and multiple pregnancy. Symptoms for the acyanotic: there's easy fatigability, breathlessness, poor feeding or interruption of sucking in babies during feeding, also poor growth, cold sweats on forehead, puffy eyelids, swollen feet, but these are uncommon in infants, and distended abdomen. An exertion may lead to chest pains, syncope, or sudden death. Cyanotic symptoms: all symptoms of acyanotic heart disease plus blue tongue and fingernails, as bluish coloration of the tongue and fingernails, as cyanosis at birth, or becoming worse with exertion in older children, and squatting several times during play in toddlers. The signs are usually elicited cyanotic signs of heart failure from moderate to severe lesions, as cold, sweaty skin, puffy eyelids, distended neck veins, and ankle edema in older children. Tachycardia, tachypnea, weak thready pulse, cardiomegaly, gallop rhythm, crepitations, rhonchi, hepatomegaly. Heart murmur is not always present. So these are the cyanotic signs. For the cyanotic signs, the signs of heart failure are present, plus finger clubbing, and also cyanosis, low peripheral oxygen saturation measured by pulse oximetry, and also heart murmur and hypercyanotic attack, that's respiratory distress with deepening cyanosis, loss of consciousness, and convulsions. So investigations are FVC, chest X-ray, ECG, and echocardiography. So the main treatment objectives are early recognition of the problem, prompt treatment of heart failure, early surgical correction if indicated, prevention of endocarditis. Non-pharmacological treatments are ensuring good nutrition, good oral and dental hygiene, avoid excessive physical exertion, notify concerned adults like parents and teachers. Pharmacological treatments for symptomatic congenital heart disease Give oxygen by face masks or nasal pumps 2 liters per minute if available, and you monitor oxygen saturation. Treatment of heart failure and symptomatic congenital heart disease, you treat it appropriately. And to improve blood flow into the lungs for patients with tetralogy of Fallot, you give propranolol oral in children 1 month to 12 years. You give 0.25 to 1 milligram per kilogram 6 to 8 hourly, with a maximum dosage of 5 milligrams per kilogram daily. And then neonates 0.25 to 1 milligram per kilogram 8 to 12 hourly, a maximum dosage of 2 milligrams per kilogram 8 hourly. Propranolol gives slow IV with ECG monitoring in children 1 month to 12 years. Give 15 to 20 microgram per kilogram 6 to 8 hourly, with a maximum dosage of 200 microgram per kilogram. 200 micrograms per kilogram repeated every 6 to 8 hours if necessary. Neonates 15 to 20 micrograms per kilogram, with a maximum dosage of 100 microgram per kilogram, repeated every 12 hours if necessary. Also, for congenital heart disease with hypercyanotic attack, you treat the hypercyanotic attack appropriately. Referral criteria: refer all children with congenital heart disease to a pediatric cardiologist or pediatrician for further clinical assessment and management.